Cancer Research UK is the world's leading cancer charity dedicated to saving lives through research, influence and information. Their pioneering work into the prevention, diagnosis and treatment of cancer is saving lives on a global scale. And together with its partners and supporters, Cancer Research UK will bring forward the day when all cancers are cured.
Thank you for downloading this podcast about the future of the war on cancer from the Economist events and sponsored by Cancer Research UK. It was recorded live as part of the War on Cancer Europe conference on November 26, 2019. The first voice you'll hear is the Economist Intelligence Unit's Chief Health Advisor, Vivek Muthu, your panel moderator.
Welcome and good morning to you. This is part of our ongoing series, global series on the war on cancer, which we host here in Europe and in Latin America and in Asia. And this year we're pleased and very proud to be part of the London Global Cancer Week. So we'll be sort of leveraging both of those in the sense that we're going to be talking, of course, about Europe, but we're also going to be extending our gaze out towards the rest of the world and be looking at the challenges, but also, as we'll see, the title here is about being cheerful but not complacent, celebrating successes but also accelerating progress. So we want to see what's working but also what needs to be done, and there's a lot. Globally, we're talking about 8.8 million deaths from cancer. This exceeds HIV/AIDS, malaria and TB mortality combined globally. The reasons to be cheerful is that we have the tools at our disposal and they're getting better all the time. We aren't deploying these tools as effectively and equitably as we can. Here we want to characterize and then bridge that gap. So we have our work cut out. I want you to participate. We of course have our panelists who will be joining us for all these sessions, but you're all experts in this room. You're all passionate in this room. That's why you're here. So we want you to engage and to ask, challenge, intervene as much as possible. So thank you for that. And I'm going to start the day actually by setting the scene, and I'm going to ask to join me on stage Henny Brond, who's Chief Executive of Anthony Nolan, Jerome Coffey, who is National Director for the National Cancer Control Programme and the Health Service Executive in Ireland, and Michelle Mitchell, Chief Executive of Cancer Research UK. And this opening plenary is really to set the scene in terms of the reasons to be cheerful, but definitely not complacent. So the two sides of the coin as we see them. So please come and join me on stage. Henny, I think it's a good place to start with you, actually, because I think it is for the patients and for future patients, which may include many of us, that we talk about this issue. So what are the successes we've had in terms of engaging patients in policy and in driving the agenda forward, and what is yet to do?
I think for me, where I've seen some successes in terms of policy and where we're listening to the patient's voice is really with the long-term plan, the NHS long-term plan. So what patients say to us very clearly is that the support, whether that's from a clinical support or from a psychological point of view, and what we're seeing in the long-term plan from the government is the commitment, and it is a commitment, and that's the important bit not to be complacent about, to have clinical nurse specialists for all patients who are going through cancer. And also where we've seen Anthony Nolan with blood cancer is the need for psychological support. Medicine doesn't stop here. And I think for patients, we've heard it very hard and loud, is that they want that psychological support as well. So those are sort of two things that I can see in terms of policy that we've seen success, and listening to that patient voice.
Mm-hmm. And in terms of where you think there are still gaps in terms of, I guess, patient engagement or listening to the needs of patients. I know the psychosocial support is something we'll be coming back to later today, and again, I agree that seems to be an area where has been relatively neglected in the past. But yes, your views on I guess where the big unmet needs are in terms of.
I think you're right. I mean, 50% of our patients are still not getting psychosocial support. I think there's also a geographical problem that we need to address. So in the Index for Cancer Preparedness, they talk very much about the global solutions and regional, but I think it's also the personal. And I think that's what's really interesting, and that's a real challenge for us all. We work in the business of cellular therapy, giving transplants to blood cancer patients. That's very much personalised medicine. So how do we meet that need, that personalised medicine, that personalised, individual, unique need for each patient? And I don't think we're there yet. I think certainly if you look at the NHS and here, it's very much about a standard pathway of care, and how do we shift that thinking? And I think that's going to be a very interesting thing for us to grapple with in terms of cost, expectation, and how genetics will play a role in that as we go forward.
Jerome, let me ask you then about policy then, in terms of the successes that we've experienced in terms of cancer control policy, but also the urgent challenges.
Well, I'm looking back over the last 10 or 15 years, we had a major policy point in the mid-2000s with a second national cancer strategy and a Minister for Health who said this is going to be a flagship program, who then went on a world tour, Europe, North America, Canada, particularly finding out what's the best model for a country our small population size, and then hired somebody, gave him direct access and significant funding. He bypassed all the usual obstacles and made a huge impact in 2 years. And that's been continued. Now we're into our third cancer strategy, and I think the tactical success was at making that a government strategy document, not a clinical program writing its own strategy. Then we can hold up every budget, the government strategy, saying it's your strategy, you really have to fund this next year. And I think that rather brutal tactic works, keeps the conversation going, keeps the funding flowing into cancer services in whole new areas like prevention, survivorship, psycho-oncology. When you take that strategy and it's got a lot of new content in it, the challenge I found is that when you do a gap analysis and you find more gaps than solid ground, then you have to go back to government saying, you know, this is important. We're lagging behind compared to other countries. The ICP document is great because it can tell you how you score, relatively speaking, even if you're not in the 28 countries. So I think those sorts of tools work really well.
Is it too early to kind of point to specific successes in terms of changes in policy or changes?
I suppose it's how do you define success? Right. Is it investment in service? Is it patient experience surveys? Or is it survival outcomes? So if you look at the end of the line, survival outcomes, so the ICBP publication recently in the Lancet Oncology showed for a lot of countries, for the common solid tumours, exactly how dramatic the change has been over the last decade or so. So it's great for us to see, because our friends in the media sometimes say, oh, Ireland's got the worst cancer survival figures, and we say, no, actually, you're well out of date with that. Look at this publication. So I think it's important that we get that longitudinal registry data, publish it, and say, well, for those tumours, we're doing okay. We've gained a lot of ground, but for one or two, say, ovarian cancer, pancreatic cancer, that's where the work needs to happen next.
And in terms of the urgent challenges, so, you know, your priorities, notwithstanding the successes there have been, what would you see those as if you had to kind of pick a couple?
Talking to people beforehand, I think there's an international competition for healthcare professionals in cancer. It's been discussed, but it's really hitting now, I think. We have a lot of vacancies that we can't fill. Nobody's applying for posts because there are jobs in large academic centres in countries with better weather. It's hard to bring trainees back or to actually bring graduates from other countries in. Right. So I think we will have increasing expectations from patients. We'll have services there, but not being able to scale them up, I think, is a challenge.
And I guess that, I mean, coming back to your point, as cancer treatment, cancer management becomes more particular, more personalised, more complex, the workforce requirements, and as the diagnostics get more, etc., the workforce requirements are going to get ever more challenging to meet. Michelle, I think the focus here I would like to bring would be really around research and innovation, and again looking at what have been the successes, and I think we have seen some remarkable science and technology come through that are enabling us to help in this issue. But what do you see as the successes, but also what are the challenges that brings?
In terms of successes, I think it's important to acknowledge more people are being treated with cancer than ever before, and more people are surviving. Survival has increased significantly here in the United Kingdom, and we have across charities, across the health system, across government, an agreement that we need to significantly improve on survival here in the United Kingdom and in England in particular. We also have reasons not to be complacent. The healthcare system is under pressure. Many of the access and performance standards that have been set aren't being met, that we are certainly not diagnosing people early enough, and a stage shift in early diagnosis would have a massive impact on survival. Yes. And the messages that we are giving at the moment, we really do need investment in our workforce, right across the board, both in terms of the new skills that we will need as technology develops, as science develops, but also the numbers of GPs, doctors, radiologists, etc. We also need capital investment in our NHS. We need a continued focus on prevention. So you talk about what are some of the things that have been very good. The long-term focus on tobacco control and smoking cessation has been absolutely critical in shifting survival over a number of decades, and we're really pleased with some of the developments around the HPV vaccine, and that will in future be available to boys as well as girls. So a focus on prevention, early detection, diagnosis is critical, but potentially in a post-Brexit world, we need to see significant investment, continued investment in research, development and innovation. The UK is in a globally competitive position. We have 2 of the top 10 universities in the world. We have a very valuable ecosystem where Cancer Research UK funds institutes and centres right across the UK and research increasingly around the world. We have significant data sets available, which will be able to ensure we're in a very data-rich research environment. And we have fantastic academics and science and innovation. So one of the things we're also calling for is ensuring that the UK remains a globally competitive place for research and innovation in potentially a post-Brexit world, and that Cancer Research UK and the charities are a serious and important player in that. I mean, I would conclude with saying that from our perspective, there's no one country, there's no business, there's no one charity, there's no one health system that will find all of the answers to beat cancer. And what we need to do is look and learn from around the world and apply the very, very best practice. Because when I speak to people with and affected by cancer, they recognise the improvements that have been made when they look to their parents' generation and their grandparents' generation before that. But people are also angry. They are also not complacent about what needs to improve. And there's a great urgency of now. So we do not want to see unnecessarily loved ones die of cancer. And so we have a collective mission working across all of those sectors and around the world to accelerate progress and to ensure more people survive.
What do you see as, so I'm interested because we're trying to have this as a sort of global discussion, what do you see as the links, the key links that from each of your perspectives you have with the global community in terms of formulating policy, in terms of patient advocacy and engagement, and in terms of R&D? So maybe we'll take that in turn. Let's start with you, Henny. I mean, how do we make sure that this is not just a UK-focused thing, but we are actually learning from and giving to the global community?
Yeah, I mean, I think it's as Michelle said. I mean, I think it has to be about working together, whether that's on a research program or whether that's for us working across borders, you know, in terms of stem cell management and looking at gene therapy. And I think those things are moving very, very fast. I think the science is almost outstripping how the health service can respond to that. And I think that gives us a lot of challenges, but we can see pockets where that's been happening for years and we can learn from that. So it's got to be around collaboration, partnership, learning, being open with our data, and that kind of transparency that will help us all learn from that. That's what's going to drive improvement.
Sure.
So I spent a lot of time getting doctors to collaborate with each other.
Yeah, that's hard.
Hospitals to collaborate with each other. It's much easier and actually probably more productive to go towards international collaboration as a small country, make a point of it with our nearest neighbours, with Europe, with the rest of the world. And I think that's where we learn. And I think it's something that's so obvious, but in my experience, it is the most important thing to do. And once you do make a decision, make a policy, make a program happen and fund it, then you need to actually be evaluation. You need to have your friends and experts coming in saying, that's correct, that's a strength, that's a weakness. So in 2014, as we were starting into our cancer strategy development, and we brought in an international panel to look at progress over the previous strategy's lifetime, and that was helpful. The government learned a lot from that, and it helped us write the next document and map out the next 10 years.
So I just divide it into 3 themes. One is global research, next is global health, and the third is global citizens. And so what we want to be able to do is save lives through research, and we want to work with the brightest and the best from around the world to ensure that we make as quick as progress as absolutely possible. That's why we've launched the second phase of our Grand Challenge programme, which is a research programme on the biggest and most audacious questions in cancer research, and we have been agnostic about where we will fund. So we have funded research from around the world, and the UK science base has absolutely been part of that and partnered up. So ensuring we are following the best science is an important part of our portfolio, and building and supporting collaboration from around the world. In terms of global health, I think our mission, our objectives around a tobacco-free world are one that we all share, and there's still significant work to be done to ensure we pursue that agenda. That agenda is not over, it's not won. If you look at a community here in Northern England, Blackpool, 22% of women in some wards in Blackpool smoke whilst being pregnant. So we need to continue to, A, make that case on a global scale together, but also in some of our communities where health outcomes are poor, where survival is poor, we have some very specific work to do and want to be part of the global health community on a number of issues, including tobacco control and eliminating cervical cancer. From a perspective of looking at the health system in the UK, it's essential, whether in Scotland, Wales, Northern Ireland or England, which each has their own health systems, health policies devolved. We need to look and learn from the best around the world about how to improve our health system and how to ensure we have the most productive environment we can for research, development and innovation. And I would just end with the point about global citizenship. Interestingly, sometimes in organisations and charities, there's a discussion about how global should we be, v. how much should we focus on our national position. Well, I look at people with cancer, and I think they increasingly see themselves as part of a global community. We provide information, and it may surprise you, but 23 million people a year come to us for expert information about cancer and treatments. Half of those are from around the world. So I think what we also need to do as charities is reach out to the global cancer community, who potentially are a huge force for good, a movement for change, and can support us in our organisations about affecting change at a global level to ultimately one day cure all cancers but improve survival in the meantime.
No single individual, charity, business or country will beat cancer alone, which is why collaboration is at the heart of Cancer Research UK's work. As the biggest independent funder of cancer research in the world, they can define global research priorities. Untethered to government funding, Cancer Research UK can react rapidly and has the agility to support courageous, risk-taking science. Cancer Research UK funds scientific and policy research in 39 countries across 6 continents. It convenes the best minds wherever they are in the world, supporting more than 4,000 researchers, doctors and nurses across a network of exceptional cancer research centres and partnering with more than 80 organisations all over the world. The charity enables its researchers to collaborate across borders and disciplines through the Grand Challenge Awards. The awards offer up to £20 million over 5 years to international, multidisciplinary research teams, giving them the freedom to try new approaches at scale in pursuit of answers to cancer's toughest questions. To date, Cancer Research UK has funded a total of 7 projects, equating to a commitment of up to £131 million.
We don't have a specific session today on workforce, and so this is really a good opportunity to talk about that, because I think that is a serious challenge, both in high-income countries and especially in low and middle-income countries. So I'd like to take that one, if I may, and how do we address that challenge? And not just from the point of view of the sort of high-tech treatments that are coming on stream, but even in terms of prevention and psychosocial support, where you do need a skilled workforce to encourage and engage on those elements. So I'd be very interested to discuss that now. How do we address that challenge?
It's probably fair to say, well, certainly in my experience, we have invested in doctors and nurses, but mostly doctors. In fact, the balance needs to shift the other direction towards. We recruited a National Lead for Psycho-Oncology last year, which is probably a decade or two too late, but we did it, and it wasn't a big investment, but that was the start of something. And there are other professional groups like that are probably more valuable than doctors, pharmacists, dietitians, all those. So in times when we've had an economic pressure, we tend to forget about that. We go for the frontline staff, but we forget there's dozens of different types of frontline staff, and we go for the high-profile ones, which tend to be the high-cost ones, thereby widening the gaps that existed before. So we've certainly looked at what our kind of recruitment should be focused on, and the feedback from the hospital is actually very positive, and from the staff, because actually it's patient liaison, patient navigator, that sort of thing. I think as we get towards far more complex care, there's a bigger challenge for information communication to individual patients, their families, and their groups. And I think that's probably something that is something we hadn't considered deeply enough before.
For me, yes, obviously it's around funding and training, but there's something about value. And it's the value we put on these posts, whether it's the CNS or the radiologist. And I think it's a shift in the way that we view those kind of posts, because it's very clear to me from the evidence and the data and from when I speak to patients that by having the right support, particularly around psychosocial, then that improves their survival. And that is the strongest argument. So it's trying to shift people's thinking in government, the funders, of the value of these posts.
So across the UK, particularly Wales, Scotland and England, we have seen ambitious cancer strategies produced. What we've not always seen published alongside them is the workforce and capital plans required to achieve really quite stretching and ambitious targets, particularly around improving survival. So what we are keen to see is a debate about, and it is happening at this moment, about what is the workforce and people plan required to meet some of the objectives around the cancer plans that we have. And that will require a number of things. Obviously, investment in nurses, where we face a significant shortfall, investment in primary care, which will increasingly be the front door to the NHS, and we have a number of people retiring and some serious issues there. But specifically on cancer, we face major gaps today. So there are large numbers of vacancies in key posts, and we do not have the numbers of specialists in a range of areas, radiologists being one of them, diagnostic staff and capacity, to get people through the system today when we know we're not accelerating progress enough. So there needs to be investment in real increases in the number of staff required to deliver the ambitious cancer plans. I think that's terribly important. So it's not an issue for tomorrow, it's an issue for today and tomorrow. And that's why people and workforce is high on the agenda at the moment.
Let's move to the question from the floor, yes.
My name's Alison Leary. I'm a Professor of Healthcare and Workforce Modelling in London and Oslo. And my question really is around, actually clinical nurse specialists are a really good example. So we've done 70 evaluations, which vary from showing clinical nurse specialists improve patient outcomes like survival to patient experience. And lots of other people have done the same. But there's a real lack of investment in this workforce, and we find the issue, particularly in the UK, is the financial constraint that employers are facing. So despite the evidence, I'll get 2 or 3 emails every day from clinical nurse specialists in cancer and other long-term conditions being asked to prove their worth. How can we influence policymakers to really address this? Because the burden of proof seems exceptionally high for this workforce.
I mean, I think just from Anthony Nolan's point of view, what we've done is fund clinical nurse specialists to almost demonstrate the value. So we're running a research project alongside that, and we will fund them for 3 years, and then the NHS takes them on. And that has been successful, but you're right, we have to always demonstrate and run the research beside it so that you get the evaluation that then proves the value to the patient, not just anecdotally, but their whole kind of ability to live well post-transplant in our case.
So we have funder recognition that we haven't done well in that area in the past. So it's not a challenge to undo things, it's actually to make faster progress. So because we have a service planning role and a budget, we can define which staff go where and what numbers. Generally we get less funding than we ask for, but that's a universal issue. The other thing we do is we do a lot of in-house education. So we will set up educational programs. We will bring every nurse in one area in for a half day or a day, so it's efficient, and we do that repeatedly. So as an educational function, it helps a lot, and it also reinforces staff in the hospital they come from.
We invest significantly in our nurse programme, and I think very happy to continue to make the case about why it's an incredibly important part of the workforce. It certainly is in an area we promote actively through the NHS and to politicians and decision makers, as we also do our clinician scientist programme as well, because we need to make sure, as well as people having the right support, and specialists are very highly valued, that the NHS is also a research-rich environment, and we're also finding that people have less and less time to conduct research, which is why we have recently launched a major investment in our clinician research scientist programme.
Any more questions? Yes, there's a question over here.
I just want to say that I am actually one of the workforce. I work for the NHS, and I am incredibly proud to be a cancer nurse. So thank you for recognising the fact that we are stretched to the limit. I run a very, very busy oncology, haematology day unit. We are 5 nurses short. We cannot fill those posts. So we work long hours trying to deliver the best care that we possibly can for our patients. So I just want to say thank you so much.
No, thank
because,
you.
to be honest, we are on our knees. And for you guys to be recognising what we do is really, really quite touching. So thank you.
Well, I want to sort of broaden out a little bit then. We've got a pot of investment in cancer control, however big that pot might be. We've got the new technologies coming out on the horizon. We've got the preventative strategies, which are ill deployed in many countries. And we've got, the needs for workforce. So my question is really about the balance. How do we spread that pot in a rational and a sensible way? And who should be engaged in that process? So I guess it's a broad question, but that's the nub of this problem that we face.
Well, I'll have a go at that one.
Go on then.
So the first thing is the pot isn't big enough. And I know you would expect a charity to say that, but it isn't. We have huge ambitions, rightly so, about improving survival. We have an ambitious cancer strategy, which the whole community, different communities are getting behind. But what we really want to see is extra funding for workforce today, extra funding for capital, because without those 2 elements, it will be difficult to make the progress that we all want to make together. So I think that's an important acknowledgement of the situation that we're in. But it's not just the NHS. So Cancer Research UK and many, many other charities contribute hugely to influencing the policy and the funding environment. So we would want to see really strong preventative policies on obesity, which is a growing issue here in the UK. We want to see continued policy and regulatory effort on smoking cessation. 2 fundamental areas. We're calling for a levy on tobacco companies to fund public health activity and smoking cessation services, because they are being cut at a local level at the moment. And we want to work together across the research, innovation, development, business, academic, health sectors, and with charities to ensure we have the best possible plans and strategies to pursue a number of areas. So I think it has to be a team effort. It's not just up to the government, but we have a number of levers. One, invest in workforce and capital today. Secondly, come together as a team to deliver on the cancer strategies across the UK, but make sure we have a focus on early diagnosis, because if we don't, we're not confident we will achieve those objectives. And thirdly, use all of the levers that we have on policy, regulation, and funding to ensure our ambitions match the plan and we have the resources. Because in the UK at least, and I'm sure this is the case around the world, people are enthusiastic and ambitious and eager to see acceleration of progress. So I think that we can come together, make the progress we need, but let's be realistic about the plan and the ingredients we must have to make this more of a success, and to ensure that we in the UK are in the future one of the best places in the world. So we have made progress, but we also are lagging behind a number of our colleagues from and countries from around the world in terms of cancer outcomes and survival. So we also have to be ambitious about the change that's needed.
Yeah, no, I absolutely agree. I think ambition is key. And there are the obvious things that we need to have a kind of rethink about how we approach healthcare and that personalised medicine. And I do think there are two things for me. One is how quickly we can respond to the scientific advances. Mm-hmm. We all expect better care. So it's about managing those expectations and changing the culture of government, of healthcare, of charities, all of us, in a way that we then respond to a very dynamic and changing environment.
So we're not standing still. I think the point about progress is important. You have to be able to demonstrate the progress you've made in the last 12 months, 24 months, and so on. With our strategy, we have a quarterly reporting process, and the government does an annual publication on it. And that's one thing. But if you talk about just services, all services want more staff, more infrastructure. I learned to stop asking a question a few years ago. I used to ask a group, by international standards, what you need. They always said 100% more staff. And you got the same answer from everybody as a starting point, and you just have to stop asking the question. But if you're in a 12-month financial cycle, the 6-month planning cycle, if you can say, right, we couldn't address that last year, we're doing it this year, then next year you either go back and top it up. So it's slow incremental progress, and over time it builds. So that is something that works when you're talking to colleagues in hospitals, talking to funders, talking to patient groups. You're saying, we can demonstrate that year we put so much funding or so many posts into that area, now we're going to go back there, but we can't do it all at once.
Any more questions from the floor? Yes, go on. Yes, Veronica.
I'm responsible for patient advocacy across Europe for Novartis. So, although I'm a Brit, I have access to data from across Europe on cancer outcomes and particularly diagnosis rates. And I would like to ask the panelists how much you look at outcomes in neighbouring countries, and what do you think are the opportunities where you see us lagging in those areas?
Just briefly, many of us here have several jobs. So one of mine, apart from the radiation oncologist, is I chair the board of the National Cancer Registry, which is a 25-year-old organisation, not the oldest in the world by any means, but it's interesting because you look at data longitudinally, and part of their remit is to work with international companion registries. So for instance, we talked about tobacco control. So we can see, because we had tobacco control legislation some time ago, incidence rates coming down or going up or whatever. So that longitudinal data, and I think what a lot of organizations do now is everything becomes public, so all data where possible can be published. So we do online, we have very simple access to most recent available data. We do subject access requests, all that sort of thing. So I think a source of information that gives you a full picture of the country of the common tumours. It came to me as a shock a few years ago saying melanoma is now the 5th most common solid tumour in our country. And I think it's helped us decide, well, in terms of drug access, in terms of pigmented lesion clinics, this needs focus now. It is not a future issue, it's a current issue.
So Cancer Research UK has been instrumental in funding the International Benchmark study. And I think it's always excellent to understand what the best in the world is doing and how we're performing against the best. We know we've made progress on breast cancer, but there's many other areas, including lung, where we must go faster and do better. And we continue to be part of that intellectual collaboration to understand our performance. So we've also, as well as funding significant basic research, we have funded a whole range of clinical trials and developed new strategies in a number of areas, not least lung, where we're looking at TracerX, the matrix lung trial, to particularly understand the evolution of lung cancer and how we can develop new treatments in what has long been described as cancers of unmet need. But the health system here, we have wonderful people, we do have reasonably good funding, we've got some fantastic outcomes depending on where you live, but we need to be challenged and we need to learn from the very best, because when you look at the countries that have succeeded, a number of those Scandinavian countries, Australia, then we have a lot to learn and we must apply that to our own health systems and own health settings.
I think just a very quick point. Sure. I think one of the things, from where I'm sitting, we work with the American and European EBMT, CRBMTR very closely looking at data. I think one of the things that we've really been tracking and picking up, which is something we need to really look at, is the chances and the better outcomes for diversity. So ethnic minority patients are losing out, and that is a real big concern for us. And I think that is something that, as a healthcare professionals, we absolutely need to get on top of.
Yeah, go ahead, please.
Thank you. Ro Lal, I'm a thoracic medical oncologist from Guy's Cancer Centre here in London. It's been really interesting to hear all your views on workforce, because as an NHS consultant, I'm acutely aware of the depleting workforce, the increasing stresses that we're under just to provide a standard of care service. What do you feel are the motivators you can provide to encourage trainees to really looking at cancer research, looking at cancer treatment delivery as career options, and also at the same time as encouraging trainees to follow those pathways? What kind of protection can you provide for those trainees, those future researchers, to make sure that they're not pulled into a struggling system to provide a really service under tough circumstances?
People is a critical part of our research plan too, so we're not just telling the NHS to fund more people within the NHS. We have invested hugely and continue to do so in our PhD programs, in our fellowships. More recently, quite a radical overhaul of our clinician scientist program, where we've put just under 50 million into that. And that is partly to ensure that people have the time and the space, as well as complete their medical training, that invest in research. So partly we're putting our money where our mouth is and continue to do that. Can I protect it and guarantee it forever? It depends if the great British public continue to give us their £10 monthly, and we inspire them to do so, because we're not funded by the government, we're funded in large part by the British public. The second thing is we influence the NHS and government to make sure, as much as possible, the overall funding is in place to deliver the cancer plan, but also that it's an environment conducive to research. We've lost that a little bit over recent years, but we continue to make that case.
At an operational level, I can write job descriptions for new and replacement posts. So I can say that clinical post has become part academic. I can say that's a clinical post, but let's double the number of sessions in the week that a person can dedicate to research. So that's the way to recruit and train. It's very basic, but assuming funding follows, I think it will be effective.
On a very small scale, we will fund PhD students, and we work within universities encouraging people into the world of stem cell transplant and cellular therapy. But it's a very small scale from our point of view.
Okay, so the next question, and let's be quick, we've got 3 minutes left.
Hi, my name's Charlie Davey. I'm a clinician in the NHS DataCan, which is one of the Health Data Research UK hubs around the United Kingdom. My question is around opportunity for access, particularly for clinical research trials. We know patients benefit from being in clinical trials, but once you go outside of the major academic centres, recruitment into trials drops off precipitously. How can we improve that to improve outcomes for our patients?
Certainly from Anthony Allen's point of view, we absolutely agree with that, and we have funded clinical trials, the first network in the UK for transplant, so absolutely, completely passionate about it. It's the one way that is going to change patient outcomes, and we were in the life sciences strategy as a beacon of good practice. So if we can raise more money, I would love to put more money into clinical trials, definitely.
Jerome and then Michelle. Yeah.
I sit in a relatively much smaller cancer research organisation in Ireland called Cancer Trials Ireland, and they were dependent on exchequer funding and industry funding entirely until about a year or two ago, and suddenly they saw the light and said we need to go out and do some proper fundraising. One horse racing event, one weekend, unexpected raised €2.5 million. So, I mean, that is money that goes into the system, into staffing, into the 8 cancer centres. We have a total of 26 hospitals delivering chemotherapy. So we need to be putting that sort of money into permanent research infrastructure, nursing admin, as well as the doctors. Most researchers in Ireland are doing it pro bono, they're not professors. So there's all that, but what are the funding streams and how do you grow them?
Just we recognise the point, the significance of it. We fund extensive number of clinical trials each year. 20,000 people are taking part currently in our clinical trials. We have expertise through our clinical trial units. We have been working with them incredibly closely to understand the current experience, the quality, and what the big change could be post-Brexit, because of course the position of the UK as being a leader in clinical trials could be threatened somewhat. So we have been also working with our clinical trial specialists to influence policy, practice, and looking at where the UK may end up post-Brexit. But 20,000 people on our clinical trials at the moment.
Okay. All right, well, thank you very much for that session. Really, really illuminating and engaging. And so thank you very much indeed.
Well, thank you to the audience.
Thank you.
Thank you for listening to this podcast from the Economist Events, sponsored by Cancer Research UK.